Corleen Kraft, president of the club, and welcome to our forum today entitled Dr. Welby and the Green Eyeshade Boys, Can Technology Rescue Healthcare? With Dr. Molly J. Coye, who's appearing as part of the David M. Lawrence, MD lectureship. Today's program is co-sponsored by the Foundation for Medical Excellence. I would like to commend you healthcare folks. Normally when I get to the lobby, the area in front of the elevators is jammed with people waiting for the elevators. In this case, there were 0 people in front of the elevators, but a whole trail of people taking the stairs. So, good for you. And I'm not telling what I did. I'd also like to recognize today representatives from the Oregon Health Information Infrastructure Collaborative, and I dare you to say that fast 3 times. Oregon Health Information Infrastructure Collaborative, which is a statewide initiative to promote secure electronic medical records and to provide just-in-time access when an individual's medical records information is required. An overview of this organization is on the information table in the back of the room. Now, if you'd be good enough to turn off your phones, if you have any, then I'd like to proceed with the announcements. Due to the holidays, we will not have a Friday forum for the next 2 weeks. I know you'll miss us. I don't even think there are going to be any reruns, but you can check pdxcityclub.org for rerun information and find out for sure. But our Friday forums will resume on January 7th, and we will begin with our State of Economy. This is what we always begin the year with, and we'll have Tom Potowski and Joe Courtwright talking to us about what's going on in the economy. We will also have our book club Citizens Read in January. It'll be held January 31st at the City Club Commons, right over here at 9th and Washington. And the book that we are reading is called Bobos in Paradise. It's by New York Times columnist David Brooks. If you enjoy his column, you'll love the book. It's co-sponsored, our Citizens Read is co-sponsored by the Portland Streetcar, and they have happily changed the name of the stop out here at the stop between Washington and Stark on 10th to the Portland City Club stop. So easy to find. You don't even have to ask anybody, you just have to attend. Norma Paulus is here today, and she is a member of our Board of Governors. She's a graduate of Willamette University School of Law, where she's currently a trustee. Norma was elected to the state legislature in 1970 and was elected as Secretary of State in 1976, the first woman to ever be elected to statewide office. She lost a close race for governor in 1986 and later served as State Superintendent of Public Instruction. And after that, she served as an adjunct professor of law at Willamette University and an Eagleton Fellow at Rutgers University. Among many other activities that she's involved in now, she chairs the Oregon's Rhodes Scholar Selection Committee. And I give you this rather extensive background on Ms. Paulus because she has the ability to pick and choose among many organizations in the community to where she could put her time, any of whom would be delighted to have her with them. And we in the City Club are delighted to have her here because she chose to be on the board of City Club. And she will share with you some of the reasons why she believes City Club membership is so worthwhile. Norma?
Thank you very much. I am very pleased to be in the City Club board. It's a great honor for me to be a new resident of Portland and then to be on the board. Thank you for asking. If there was ever a time for our citizens to know more about their governments and be more involved with the governments and understand the issues, it's now. And I think that the City Club is one of the better ways to get informed about major issues. During my first session, I served in the legislature. I was there before Vera and Earl and Steve Gafori. It was just the session before. But Betty Roberts was then my mentor. She had been in the House and the Senate. And I first became acquainted with the City Club over television because I watched Vera and Betty and Gretchen, in a very militant fashion, trying to get women members into this institution. And once they did, I had then gotten to know all of them because they were down in the legislature. And so I've been following the reports and the issues and the speeches, the activities of the Portland City Club throughout my political career. And the reason I have been is because I found at the very beginning that the process for examining the issues was very thorough, nonpartisan, and involved some of the major citizens and experts on these issues. So I've always been involved with the City Club, always paid attention to it, and I know that the legislators do. And I'm hoping that that's true this year also, because our elected leaders are dealing with bigger problems and smaller budgets. They need as much input as citizens can give them and institutions like this can give them. It's very dismaying to see what's been not happening in our state the last few years. Our legislature has reached one stalemate after another, and the parties are more divided than they've ever been. So I would ask that you practice that nonpartisanship, speak about it to your legislators, say that you want them to act like our two senators, Wyden and Smith, and work together. But I also think that you as members and as citizens, members of this organization and citizen, too, that you have a responsibility to reach out and help us find more members. And so today I would ask that you not only join up again, retain your membership, but ask a neighbor, a coworker, or a relative. You can even ask your mother-in-law if you want to. And I promise you won't have to sit with her, I'll sit with her. But I do encourage you, and I would like to have a show of hands of all of those members sitting here today that will pledge to seek out one new membership besides your own. Thank you very much, and I am delighted to be here, and I'm looking forward to your speech. Thank you.
Thank you, Norma. And membership brochures are on your table, or you can get one. Membership applications are on your table, or you can get one from the staff as you leave today. So please do join us. While the Friday forums are a very public face of City Club, and our research reports are a public face, one of the not so public faces are our issue committees. And we have 6 issue committees that allow members of the City Club to become involved in an area that they find very interesting and to get more deeply involved and get more information on it. Our 6 issue committees are Arts and Culture, Education and Human Development, Citizenship and Government, Growth Management and Environment, and Healthcare. And their agendas vary just depending on the interest of the members of the committees at that time. But today we have a report from the very ambitious Healthcare Issues Committee. They've done extraordinary work in researching this area, and their report examining the healthcare safety net in the Portland area can be found in the bulletin on your table or in the back of the room. It's the 3rd in a series of reports from this committee, which is very ambitious work. The first provided background on the Oregon Health Plan. The second identified gaps in healthcare access despite the implementation of the Oregon Health Plan. And this 3rd and final report describes the Portland area's healthcare safety net, the source of healthcare for those who lack care from mainstream providers. I'd like to introduce Barbara Prow, who is the chair of the committee, and I'd also like to point out that the committee who did all this hard work is sitting right here in this table. Barbara will briefly outline the highlights of the report. Barbara has a bachelor's degree in pharmacy and an MBA from Kellogg Graduate School of Management, and she has marketing, management, and consulting experience in pharmacy, home health care, and employee benefits, now consulting with Working Solutions, which is a division of United Healthcare here in Portland. Barbara Prow.
Thank you. I am honored to represent the Health Issues Committee of City Club in presenting to you today, examining the healthcare safety net in the Portland area. This report culminates 2 years of research by the committee members who you see here today. A few are represented. And on page 43 of the report, you could see the names of all of the committee members who worked on this report. 2 key City Club contributors are not here today, and I feel they deserve tremendous recognition. The first is our former co-chair, Ted Falk. Ted really was the key leadership throughout the research phase of this report and took on the daunting task of collating all of the information that we gathered into the first draft of the report. Secondarily, I'd like to mention City Club Research Director Wade Fickler, who then took that report and in conjunction with Leslie Moorhead, who is here today, our research advisor, and brought that into a readable report that you have in front of you today. And Wade is editor extraordinaire. He's just incredible to work with. In addition to that group, there are 30 community healthcare leaders and professionals who offered time, tours, and information toward this report, and then new information throughout the course of this past summer as information regarding the safety net had shifted and changed. As you all know, the healthcare budget for the Oregon Health Plan and the state revenues have been moving targets over the past few years, so the numbers in the reports have been moving targets. We could not have done the report without that group of 30 people, and I would really like to have you take a look at pages 48 and 49 of the report where all of their names are mentioned, and we are greatly in their debt. To keep the report readable and manageable in scope, we needed to make some difficult decisions. One was to limit the scope of the report to Clackamas, Multnomah, and Washington counties. The second was to not include mental health. The exploration of mental health within the safety net is a report that's just begging to be written. And if any of you have the time and energy, I urge you to spearhead that task. It is with some mixed emotion that I stand before you today. On the one hand, I'm absolutely thrilled that we could provide this report. On the other hand, there is a tremendous sadness that in this country we actually need a healthcare safety net. And we do need it. And the aim of our report was really to assist City Club members and the community in understanding the safety net and to stimulate involvement. City Club is not alone in exploring the issues of the healthcare safety net. Economic constraints of the recent years have exacerbated an already precarious situation within our fragmented healthcare system. In 2002, President Bush pledged to double the number of patients served at federally qualified health centers, which are the backbone of the safety net, over these 5 years. Last month, the Kaiser Family Foundation released a report that states that only half of the uninsured are aware that the safety net exists. And just this week at the Oregon Healthcare Summit, the governor's Health and Human Services advisor mentioned that the governor is very concerned about the healthcare safety net. However, the healthcare safety net exists only where local communities create it and nurture it. The term safety net implies a strong, buoyant, coordinated system. In reality, the safety net is a loosely comprised network of devoted providers that deliver a significant level of health care to those who are uninsured, who are covered by government programs but cannot find a physician willing to take the lower payments of government, or those who lack the capacity to navigate mainstream care. The safety net is where the approximate 210,000 residents of the Tri-County find health care. That's approximately 15% of our population. Despite the fact that I have used the word research a couple of times, this report is an informational report, not a formal research report of City Club. Consequently, conclusions are not drawn, nor are recommendations made for City Club action. However, since I have the microphone for another minute, we do hope to focus attention on the safety net, stimulate discussion, prompt new solutions, and explore advocacy opportunities. Within the arena of new solutions, please make note of pages 38 to 41, where there are brief overviews of a couple of innovative efforts that are taking place in the Tri-County area. And those are the Oregon Community Health Information Network and the Safety Net Enterprise. In closing, I urge you to read the report, give it to family and friends, Christmas stocking stuffers, just don't throw it away with the holiday wrap. Share the report with legislators, policymakers, foundations, etc. Learn how you can help the safety net clinics in your community. Vote for and support legislators who are sympathetic to the need for creative healthcare system solutions. Our hope with this report is that it will be one element in a widening circle of solutions, and with your help, it will be. Thank you. Thank you very much.
With dedicated leaders like that, I think we're well on our way. Thanks so much, Barbara and committee. Details of all of the events that we mention here are available online, and I would like to mention that this report is also available online. If you go to pdxcityclub.org, you can find that and details of all of the other activities, as well as our citizens blog, if you'd like to participate in an online conversation about some events. Audio CDs and videotapes of today's program are also available. And our sponsors this quarter are Nike Incorporated, Portland General Electric, and Preston Gates and Ellis LLP. We're very grateful for their support and their sponsorship. Now we'll get to our program. Dr. Lawrence had suffered from what many of us do, which is a delayed flight, but we're so happy that he could be here today. We're going to recognize him and let him eat his lunch because he will not be speaking, but I'd like to recognize his leadership. He began his career with Northwest Permanente Medical Group in 1991 and went on to become, well, he did not begin his career in 1991. He began it here in 1991. And he went on to become CEO in 1991, then chairman of the boards of Kaiser Foundation Health Plan and Kaiser Foundation Hospitals from 1992 until retirement in 2002. He currently serves on the boards of several companies and serves in advisory roles in the biotech industry. So thank you for being here. We're so happy that you could make it. And now we'll get on with the program with Dr. Molly Joel Coye. She is internationally known for her work in patient safety and high health technology. She is founder of the Health Technology Center, which is a nonprofit organization established in the year 2000, dedicated to advancing the use of beneficial technologies for healthier people and communities. She previously served as Commissioner of Health for the state of New Jersey, head of the Division of Public Health at the Johns Hopkins School of Hygiene and Public Health, and the Director of the California Department of Health Services. Dr. Coye is a member of the Board of Trustees of the American Hospital Association and was a founding board member of the California Endowment, which is the largest private philanthropy in healthcare in California. She's currently a member of the Board of Trustees of the Program for Appropriate Technology in Health. Dr. Coye, welcome.
Thank you very much, and thank you very much for the honor of being here today. Many of you know David very well, and I think we should start out with apologies to David, because in my experience, I've never known him to come so far, so fast, at such effort, and not get to talk when he got there. So our apologies, David, and you will have a chance to speak at the end and rebuttal if you want. But I thought that the title of Marcus Welby and the Green Eye Shade Boys, it was very expressive not only of the topics that I want to cover, specifically how technology can help us solve some of the most important problems before us in healthcare, but also some of the many contributions that David has made to healthcare nationally, as well as in Oregon and in California. First of all, though, stop and think of why there are some obvious similarities. For for those of you who know David, you know him as someone who embodies a lot of the characteristics that the screenwriters crafted so carefully for Dr. Welby. He is someone who we trust, and truly do. I'm not saying this to be funny. We truly trust his leadership, and it has been very important to many of us in our work as scholars, as other leaders in healthcare, and as many, many employees and physicians and colleagues working with David to build health systems. His sense of humor. I don't know if you grew up watching Dr. Welby, but that was actually a characteristic. He used to twinkle and sort of laugh at the ironies of the situations before him, and David's sense of irony is very well developed, and I'm sure that's why he's managed to survive so many tribulations in his life. But the other characteristics are deep caring and intelligence. And I think all patients and also all healthcare workers, whether you're an administrator or a physician or a nurse, want to work with other people in healthcare who bring those characteristics to their work and are as dedicated as David has been. So I belong to a very large posse of people, David's posse, of those who respect him and have tried to follow some, if not all, of the examples he's set. There are some things that he's good at that none of us will achieve. But just as an example, Don Berwick, who I think many of us would recognize as the father of healthcare quality in the United States, cited David as his mentor when he received the American Hospital Association Trust Award for Excellence in Healthcare a year ago. And he talked about how important it was that David understood and led in understanding that trust is absolutely central. We can be technically proficient. We can organize a system to a fare thee well. But if we can't communicate and conduct ourselves in a way that inspires trust in our patients and their families and in the employees and participants in healthcare systems, we will not be successful. And I think as the speaker just before me who'd done the study on the safety net experienced, that we're an increasingly fragmented healthcare system. And trust is something that is won over time with collaboration and work together. And that's what David wrote about in his book, From Chaos to Care, in Integrated Medicine, that a group of healthcare providers who trust each other and work with the patient can provide care that is truly trustworthy. Now, you also have to realize that as an author, he has probably a new experience. Very few health wonks like David are listed on Amazon.com. So if you go in to order more copies of the book, as I did in the last couple of months, you will find that he has 4.5 stars. So congratulations, David. You have reached a new high as a policy wonk author. So I'm going to talk today using a baseball analogy. I happen to know that David likes baseball and has been a long time aficionado and understands it far more than I do. But I have a son who grew up loving baseball, and so I've become a baseball mom, and I've learned a fair amount along the way. And I'm going to start out by recommending another book besides David that you might read if you haven't, which is by Michael Lewis, who wrote Liar's Poker. But he also wrote a book called Moneyball. Has anyone here read this? Oh, a fair number of people. Very good. Moneyball is the story of the Oakland Athletics, David's home team. And for healthcare aficionados, many of you may not work in healthcare, or some of you may not, but those who care enough about it to come out for a lecture about healthcare, this is a book about baseball, but it could have been written about healthcare, because it basically talks about how important knowing the statistics, being able to get information about what you're doing is. And the story of healthcare for the last several decades has been that we didn't really know what we're doing. We don't have good information about what we're doing and what the results are and how it compares to others so that we can improve our performance. So a lot of the bottom line is trying to begin to use, whether you call it epidemiology, healthcare information systems, to use good information to guide us in our work in healthcare. Billy Bean, the manager of the Oakland Athletics, used good information. He used statistics instead of just what the Scouts, which is sort of the old boys club, told him would be successful. The Scouts would go out and eyeball someone and say, "This looks like a pitcher to me. This kid carries himself like a pitcher. He acts like a pitcher. So let's hire him." And instead, Bean actually said, "We're not taking very many people out of high school. We're only taking them out of college because then we will have had a chance to see them accumulate some meaningful statistics. And we'll only hire people where we have some understanding of what we're doing. And because we don't have a lot of money, we can afford to hire people who are actually very good but don't look like a pitcher." So there's some secret keys to effectiveness and efficiency in this. You may find out once you finally have information about outcomes and what works that can guide you to surprising conclusions about how you actually can save money and improve performance. That there are real reasons to want to know what we're doing. So as I head into this, the mantra that I would like to communicate today is to find and invest in early solutions. David has been a pioneer much of his life, and you're not always right when you find and invest in early solutions, but in the end, you create institutions of real excellence. And the Kaiser Health System in California, which is the one I know best because in addition to being a policy wonk following how they do, I also am a Kaiser member and patient for the last 15 years. So I've gotten to see on the receiving end the various policies that David espoused and supported. What we saw was the creation of a care management institute that took what could be known about care in Kaiser and tried to drive it closer and closer to clinical protocols centered around the best of care. So long before most of the rest of the world was doing it or even could do it, trying to come closer to medical standards of excellence. Secondly, investing in the electronic health record. Outside of the government, they will make the largest single investment in the world over the years, starting with David's tenure, in the construction of electronic medical record. And also to bring it down to a much more practical level, David led Kaiser in investing in a program which continues today called CarePanion, which provides very practical services and supports and products for people who are living with severe chronic disease or disability for them and for their families. Understanding that it's not just the medical care that helps a family. If you want to help the family, you have to reach out beyond the medical care itself. So what would this mean if we found and invested in early solutions? Let me take us way outside of healthcare for a minute and say, how many of you have a Roomba? Not yet. Do you? Roomba. No, not a boombox. No. I saw two hands. Any more? A Roomba. A Roomba is a vacuum cleaner that looks like a satellite. You buy it over the internet. There aren't many places to buy it otherwise. You turn it on and you walk out of the room. You close the door and you go to work. And it vacuums the house while you're gone. Now, it doesn't do windows and it doesn't do drapes, but it won't eat the pet and it doesn't fall down the stairs. This little round thing just goes around and cleans your rugs and your floors. And this is selling like hotcakes. It looks like a hotcake. It really looks like a satellite. And it is disrupting the home maintenance industry because Hoover and all the other big companies that sell traditional vacuum cleaners have to worry about the Roomba. So most of the technologies that are really going to make a difference in healthcare are pretty disruptive. So by definition, even if there is same year or second or third year ROI, which not all of them have, even if they're better than sliced bread or better than Hoover, they are very hard to implement. This is hard work in healthcare because the cultural change the management of introducing a new technology is a slow process. But let me give you an example of congestive heart failure. How many people here have a relative with congestive heart failure? Yeah, not surprising. Congestive heart failure is one of the top reasons why people come to the emergency department or are admitted to a hospital. And the usual period of time between them starting to get sick and winding up in the emergency department is 5 days. There's a long period of time when the patient knows something's not right. They're starting to have trouble breathing, sitting up with more pillows at night, until they finally, and usually they call 911, because all of a sudden they really can't breathe, and the ambulance comes and takes them to the emergency department. They're hospitalized for 5 or 6 days. The cost might be $12,000, $15,000, and they go home, and on average, if they're into that, they're coming at least twice a year for hospitalization. So it's a very unhappy life, and it is also a very expensive way to care for this disease. What we know is that we can put a scale in the home hooked up electronically to a little box about this big and to a telephone, and through the telephone to a central triage system. And so that patient can be monitored at home. So every day, if you have CHF, you're supposed to get on the scale and be monitored, and you are supposed to take your medicines. And people get in trouble because they don't do this. You get on a scale to see if you're adding weight because you're retaining fluid. You can't get rid of the excess fluid. So if Sam doesn't get on the scale, the phone rings and says, "Hey, Sam, get on the scale." If he gets on the scale, then the little box says to him, or if he's hard of hearing, there's an LED display, and it says, "Sam, did you take your meds today?" And this is not complicated technology. There's a yes button and a no button. That's all he has to do. But if he's starting to put on weight, then there's a script in the little box asks him a couple more questions. Did you need more pillows to sleep last night? And the result of a system like that is that there is a 32% reduction in hospitalizations. More than, or almost, sorry, make sure I'm right here, almost a third of the hospitalizations are reduced within a couple of months. All of a sudden, Sam can be taken care of at home. The cost savings is about 25% of the annual expenditures, or approximately $1,800 per patient. This is pretty substantial. It leverages the use of RNs because Sam talks with an RN on the phone when he's starting in that 5-day cycle of getting in trouble, rather than having to come to the doctor's office. It also results in an increased level of education for Sam and his family. The national savings, just in congestive heart failure for the adoption of these devices, at only 25% of patients using them, if only 25% of CHF patients use them, is estimated at about $500 million. At 50% adoption, $1 billion. So one of the things, as I used to say on Saturday Night Live, talk amongst yourselves. One of the things to talk about as you leave today is what are the barriers that keep us from doing that? I was a part of the Institute of Medicine committee that wrote To Err is Human and Crossing the Quality Chasm. And David not only was a member of the committee, he was, along with Don Berwick, the leading members of the committee, and he authored the phrase for us about crossing the quality chasm. And part of what we said in those books was we've got to change the reimbursement system in order to get real quality change. Because a hospital that loses that much money is going to be in serious trouble. We have to have a system that allows for the introduction of quality improvements and helps us ease through these transitions and reinvest the savings in improved care. We also said that we need information technology. that if we don't have information technology, we don't know where we have problems and where we can save money and improve the quality of care. Let me just do a quick check. I'm not sure what time I'm aiming for as the end here. Okay, very good, thank you. Okay, well, I have time then to share with you one of the most important examples of this need to speed up, to find the early solutions. And that comes from a movie. I happen to be a real trash movie fan. I even like Bad Boys 2, so I have all kinds of confessions. But one of the films, which I don't think was so bad, that I really loved was Master and Commander. And I assume a fair number of you probably saw that. Well, remember when the officers were below deck and sort of celebrating, and they all clanked their tankards, and they were so happy and healthy and hale and hearty? Stop and think a minute. Only 50 or 60 years before the setting of that movie, about 40% of the members of that crew would have died on any given voyage. Not from the military engagements, but from scurvy. But the solution to scurvy was discovered 268 years earlier. A British surgeon did the first clinical trial in history, the first randomized trial. 4 ships left London and sailed to India. One of them had lemons on board. Nobody died on that ship, and 40 to 50% of the people on the other ships died. Didn't lead to any action at all. It took them hundreds of years to get to the point of action. Some of the people in healthcare may know how long it takes us in healthcare, from finding that an innovation is good medical practice, really makes a substantial difference, is an improvement. How many years until we adopt it into practice? 17 years on average. 17 years of people being sick when they don't have to be sick, of spending money that doesn't need to be wasted in our healthcare system. So, what are these new innovations that the Green Eye Shade boys might support? Because luckily, a fair number of quality improvements also save money. The problem is they often don't save money for the same folks as those who invest in it. And that's the need for realigning incentives. But let me just tick off quickly some examples. What would that look like? There is a communication system called Vocera, which is a little device you hang around your neck. And everybody who walks into a clinic or a hospital puts it on in the morning, and you can not only call Dr. Jones, you can call a radiology technician anywhere in the hospital, you can call a rad tech on 4 West, you can call all the rad techs. Now I need to stop for a second and assure you, I run a nonprofit think tank, a research organization, which Kaiser and Peace Health and Providence were all founding members of. And we don't take any funding at all from the companies that develop technology or sell it. So when I tell you about technologies, they are ones that Peace Health and Providence and Kaiser have helped us do the research on, but we have no stake in them as technologies. So there's the Vocera communication system. There is point-of-care lab testing. There's lab testing where instead of sending the blood tube off to the lab, it's at the bedside. And you have the results instantaneously. Barcoding, like your grocery supplies, for all of the drugs in the hospital or in the clinic. Radio frequency ID tags, which is a step beyond barcoding, RFID, so that you know where all of the equipment and the patients are in the hospital at any time. Well, why would that be so hard? Have you ever had a relative get lost going to radiology? You know, they're a patient and they're sent down to radiology and nobody remembers to bring them back for 3 hours because they didn't know where they were. Or nurses will hide the IV poles because there aren't enough of them and they're always keeping a few extra in their closet. I heard a few laughs about that one. So simple RFID tags. There are also much bigger things to take on. The electronic ICU, which we believe in our research on the future of healthcare will be absolutely central. We will have remote support for the management, not just of ICU care, where it's been shown to cut mortality, death rates by a third and expenses by a third, but also for rural hospitals, for emergency departments. Remote management will become a standard of care. Now, what is the green eye shade boy response to some of these? You have 3 million people in Oregon, roughly, right? In Massachusetts, they did an analysis of what 7 of these leading technologies would do for health expenditures in Massachusetts, and it would save almost $3 billion a year. So I actually don't know what the total health expenditures in Oregon are, but that's a pretty substantial number. That's a lot of savings, and every one of these would improve the life of patients and the ability of doctors and nurses to provide the care they want to. It includes electronic prescribing. It includes ambulatory physician order entry and in the hospital, so that all the orders and the drugs are electronically entered. It includes the electronic ICU that I just mentioned. Disease management, so that people who have chronic diseases have a comprehensive integrated care system similar to what David describes in his book. It also, all of these things are things that exist now. These are not technologies that are on the horizon yet to come. But we would need substantial investment. In every state, in every region, we need substantial investment, and we need to have some modification of the reimbursement system so that we can align the incentives so that doctors and hospitals and health plans and patients and their families all have the same interest and all benefit when the patient does well. So in the end, there are solutions which the green eye shade boys, if they stepped back, would really say, yeah, this pencils out. This makes sense. There are early solutions, but what it takes is collaboration and trust and courage. And I'll leave you with the example of the real early adopter of the scurvy story. The early adopter, about 100 years into that 300-year period, about 100 years from the end. So 100 years before the British Merchant Marine turned them all into limeys, was Captain James Cook, who you remember was killed in Hawaii. But before that, he sailed to the Arctic, Antarctic, Australia, all around the world, and lost almost no sailors at a time when 40% of the sailors were dying. And the reason was that he figured out that sauerkraut does the same thing that limes and lemons do. And he forced his crews and his officers, sometimes at sword point, to eat sauerkraut. I don't know how you feel about sauerkraut, but it worked. They survived. He didn't, unfortunately, at the hands of the Hawaiians. But it shows that sometimes if what you care about passionately is improving things, you can even approximate the very best final solution and come up with things that are good enough that will make a tremendous difference. So I hope that as we play out this next decade in healthcare, we will live out the guidance that David gave us. David Lawrence was a fabulous leader. He's still working very hard and very closely with many of us, and I hope that we can carry his spirit forward.
Spoke her name. In any case, we now have the opportunity to ask some questions of Dr. Coye. Bill Kramer, who is our board host today, is a member of the, he's a treasurer of the club, and he chairs the finance committee, and he is a health policy and healthcare consultant. Our Members are typically the only ones who can ask questions, but today the Foundation for Medical Excellence, our co-sponsors, are also welcome to ask questions. There are 2 microphones here, and Dr. Coye will begin to answer your questions after she answers Bill's question.
Thank you, Dr. Coye, for a very thought-provoking talk. Early in my career, I was a medical economist working for Dr. Lawrence in California, so I'm going to ask a question, of course, about costs. One of the most serious problems in healthcare is affordability. You and others have talked about the potential for information technology to reduce costs and improve affordability. My question, though, is given the current structure of the healthcare market, can IT really improve affordability, or what else is needed to capture the potential of information technology?
That's almost unfair. It's lining up exactly the question that I would have loved to answer. I think that it's very important to recognize the difference between the practical capability of technology. We know technologies right now that can make care less expensive and better, and the problems of our system in actually getting there. Because when the system is as fragmented as it is, for example, one system may be able to invest in the IT, the information technology that's needed, and another one may not have the capability to do it because they're a safety net provider or they've had a bad couple of years. Secondly, even the hospital system, because it's really the hospital systems more than individual physicians who have the resources to invest in some of this, even if they do that, they're liable to see within a year or 2 their revenues go down markedly, and here they were the ones that actually funded all of this in order to try and get the improvement. So there are some models that are very helpful in this regard. Clearly, the provider-based health plans like Kaiser and Group Health have part of the solution in the sense that they can align these incentives. But as David will tell you, it is not an easy job. It's not a slam dunk. And if it was, we would see even larger differences than we do today. I think that the most important answer is community collaboration, is the provider systems coming together to say, how can we in the next 5 to 10 years make sure that every physician, every care provider, every hospital and nursing home has the capability to get basic data, to have the basic electronic capability, and to exchange that information. So when the patient goes from the nursing home to the hospital to the home care agency, there is a way to follow that information and know what's going on. This is now a national campaign, and I'm meeting with some individuals this afternoon who are working very hard on this in Oregon. We're starting that effort in California. This is going to take resources way beyond what our current hospitals can underwrite, but it's something that everybody will contribute to, we hope. So let me stop there and open it up.
Chris Allman, Portland City Club. About 15 years ago, my husband and I both came on board to Kaiser. I was an internist, he is a radiologist. And at the time, there was a lot more screening in terms of studies that were done as a radiologist for scans, CTs, MRIs. But with community standards dictating that every corner practically have an MRI, things have drastically altered and the utilization has skyrocketed, lending to increased costs. How do you factor in that with the cost of technology and community standards?
An excellent question. And it was a central one for us on the Institute of Medicine committee that David and I were both on. And that's why we said that reimbursement systems need modification, because if the imaging centers make money, the more imaging they do, the more money they make, then that incentive runs counter to many situations in which it may not be clinically necessary. Secondly, in many cases, that means that something that might have contributed to a community hospital's ability to stay afloat moves out of the hospital and erodes the ability of that hospital to continue to provide emergency room services. When you have a very fragmented system, nobody really comes out smelling like a rose because everybody has to stay alive. People aren't doing most of this for venal purposes. They're just trying to stay alive. Those contradictory incentives are a real difficulty. I don't think that technology solves that. The solution to that is social purpose and community collaboration, and also having the IT, the information technology, so we can look at the outcomes and the investment. If we see how much does it cost to take care of a person with a stroke in one health system and then in another health system and what the outcomes are like, we can't do that today very well. But if we could do that, we could say, well, look at this system, does it without as many imaging studies, but they use the right ones and they do it when it's needed, it costs less and there's better outcomes. That's where we want to get to.
I think your point is well taken that without an integrated system, these technologies are difficult to implement. And I think we are lagging behind the other industrialized countries that do have integrated systems as far as communication goes and monitoring chronic diseases. But I'm curious, with your background in public health, how you would view the lack of access in this country with the technology really being irrelevant to folks without access, and that this is another driver of tremendous cost and waste in the system. Neglected patients that have no access, hospitals are closing, and doctors are leaving town because of lack of reimbursement. Our insurance premiums are rising. Would you have a solution to this?
Yeah, two things. First of all, as the Institute of Medicine does and most medical groups do, I strongly support the extension of access to health insurance for everybody in the country. I mean, there's no question about that. It also is, however, very true that some of this technology can make a huge difference for underserved populations with access problems. For the amount of money we currently spend, because there's a fair amount of money spent on people who don't have insurance, through public hospitals, federal clinics, a whole number of, and also the charity care that's often provided. If more of that money were used, for example, in the monitoring of chronic disease, many of the people who don't have health insurance and have access problems now would be considerably healthier. So there are ways in which we can solve part of the problem by making the dollars go much further. But ultimately, we can't solve it until we provide health insurance for all.
I'm Susan Pierce, member and a semi-retired hospice, home health, and home infusion nurse for the same organization as Dr. Lawrence, and a long-time employee of that organization, so I've been through a lot of those changes, not the least of which was the joys and woes of electronic documentation 10 years ago. Bill Kramer took one of my questions, so the other question is, several weeks ago we had a presentation from a gentleman who spoke about the importance to people of telling their stories, which brings to mind the importance of face-to-face contact between, among other things, the healthcare provider and the patient, and the importance to the patient of having the opportunity to tell their story. So could you talk a little bit about how we mesh the technology and maintaining that personal contact?
Yeah, and I think this is one of the areas where, again, our image of technology doesn't necessarily have to be the reality. There are, for example, many people who live in rural areas, and even with the best access, if they had full insurance, they wouldn't get to be face-to-face with a healthcare provider very often, under most circumstances. With a video two-way system in their home, they get to talk face-to-face with a nurse practitioner or a physician when needed. So technology can be used to approximate it in ways that do add to the quality of care for those patients. For someone who's just had a cancer diagnosis, you don't want to sit down in a two-way video system. You want to sit down with a provider. So there's some things that technology won't solve, but by offloading or improving other situations, you can focus the resources, the time of the individual care providers where it's most needed. I can't, for example, other than just having the information in the medical records, imagine a lot of ways in a hospice situation where technology is going to be critical. You would want to have good records, but beyond that, you want human beings there. But there's a lot of other care that could be assisted in this way.
Hi, David Poole, City Club member. You talked about community collaboration, sharing data, working together. When it comes to software development, that more describes the process of open source software rather than proprietary software. Here in Portland, we're blessed with kind of being a worldwide leader in open source, and we have foundations like the Meyer Memorial Trust that has helped fund development of an electronic medical records application for mental health. I'm just wondering to what extent that's on the radar of big think tank folks and large organizations.
The question was about open source systems, and it is front and central. I didn't have enough time to go into it, but we're very involved with the Office of the National IT Coordinator that was just established last year. And David Brailer is the National IT Czar, the leader of this. He was a fellow in our center, in our think tank, before he took that job. And we're working with him on a number of things. One of them is to establish the national backbone that will be used for, if you want to send your medical record to Florida, this kind of communication. And one of the principles we're using in trying to put that together is open architecture. So it's absolutely core to almost every solution. We can't afford not to.
I'm Don Wagner, and I'm part of the Aging Society, and there's lots of people going to join us. Lots and lots, those boomers are going to be. So here we have this burgeoning elderly, there's no better word for that. But anyway, okay, there's a better word for it. What did you say? Well, aging, but mature. Yes, yeah. And so here we are, we're coming. The only thing I am observing is that healthcare costs seem to be going up rapidly, at least according to the things I see. And I see the good things that you're working on. As a think tank person, do you see some points of pressure where, like we said, JFK says, let's go to the moon. And so people get behind it. Is there some kind of things that you would recommend, or perhaps even some things that you see happening that can really make a difference? Because we're really heading for a bad fall, I think.
Yeah. That is very much the assumption of most people in this sort of policy wonk world looking at this. Politically, some people don't face up to that, but it is definitely a problem that we're heading for. And I don't know if we will be capable of really moderating the rate of increase. In the best of worlds, many of these investments in technology, some of them information technology, and some that I didn't talk about are clinical technologies that just for congestive heart failure, things that would really improve people's health and shorten their stay or keep them out of the hospital. There are many technologies. The question is not the lack of technology. The question is the fragmentation of the system and the contradictory incentives. As long as that stays in place, I am very concerned that we may actually accomplish much slower than we should the investment in information technology, but we will never harvest the gains. We will never really see costs be moderated. I don't think we'll ever see costs go down, but we could slow the rate of rise. So I really think that's an open question. I'm not at all clear that we will have the social will to try and build more aligned systems. I know many hospital administrators who are very frustrated because they know that things could be done better, but it's a logjam, it's a gridlock in terms of the incentives. Okay. Thank you very much.
Thank you so much for a very interesting program, and thank you, Dr. Lawrence, for having provided the forum that we can have speakers such as this. We are adjourned. Happy holidays, everyone, and we'll see you here on the 7th.